Well, hello and welcome, welcome. I'm so excited that we are here today on the Functional Nutrition Counseling for Clinicians YouTube channel, Facebook pages with a very special guest. I'm excited to introduce you to my dear friend, Dr. Nalini Chilkov, who is founder of the American Institute of Integrative Oncology, where she provides online training for frontline clinicians so that they can support the health of cancer patients and cancer survivors at every stage of the cancer journey. Over 35 years in practice, she has treated thousands of patients and transformed many lives, including many of the lives of those of us who have not experienced cancer personally, but who have worked with those with cancer. And personally, she's just such a dear, amazing person, and you're going to love this conversation. I know many of you probably are already familiar with Dr. Nalini. Dr. Nalini now teaches her OutSmart Cancer System to care providers through her professional online training courses to further her mission of changing the face of cancer care and empowering clinicians to develop the clinical skills to serve this rising tide of patients in need. Welcome, 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 Dr. Nalini. I've got to change our background so we're not so crazy here. Hi, Dr. Nalini.
Hi. Thank you so much.
Yeah, and I just want to mention quickly that we do have Brandon Roa on my team here in the chat. She's here to say hello. If you have any comments or questions, put them in there. Brandon's going to be answering and really pointing out if there's anything I need to bring to Dr. Nalini's attention. So, Dr. Nalini, my first question for you as we dive in today is just a little background, if you don't mind. Before we focus on the unique needs of cancer survivors, can you tell us about your OutSmart Cancer System and just how you came to specialize in integrative cancer care?
Well, there's always a personal story, isn't there? And so when I was when my parents were in their 50s, they both were diagnosed with different types of cancer. And so then it was really personal. And I really understood that my whole family might have risk of cancer. And so I took a deep dive into looking at how to really help people through their treatment process and reduce recurrence, but really how to look at where risk is. And then, of course, both of my parents were cancer survivors. And so then what's the long-term plan to not have a recurrence, but also to have a long, healthy life? And so they were diagnosed in their 50s and had their cancer treatments in their 50s. And my mom died at 88. My dad died at 90 of cardiovascular disease, not of cancer. So that's my wish, that everyone has that story as their, post-cancer experience. So we're going to talk about what survivors need today. And my OutSmart Cancer System sort of developed organically as I started to work with cancer patients. And really, it's a health model so that I really feel that every cancer patient should have a plan for their health and not just a plan for their disease. And sort of the model of oncology care is this sort of hit medicine, and it's very intense. And then it's over, and then the cancer patient is like, what's next? And they've had all this high touch, frequent interaction with their care providers, and then all of a sudden it ends. And at that moment, then what are the needs? And so it's in the functional medicine community that we have the paradigm and we have the toolbox to help them recover from their treatments and really do a personalized approach and have a health model. And the word health doesn't even come up in the oncology clinic, right? It's just not in the lexicon. And so it's really important that cancer patients and survivors have a place to go, have resource people, have clinicians that are well-trained, understand what they've been through, what their unique needs are. So let's say you have a patient who comes to you as a new patient with a complaint of fatigue. If they just went through chemo, that's a different project than if they're hypothyroid. And so I just feel clinicians are not well trained in what cancer survivors really need. And so the OutSmart Cancer System is a health model for clinicians, frontline clinicians.
I love that because there's so many aspects of cancer care that you're pointing out, both through treatment, after treatment, dealing with the impacts of and insults of
Yes,
treatment. Like
yes,
there's
yes.
so much that is being overlooked. And also, you pointed to something that I think is really critical in terms of empathy and real patient centered care, which is that a lot of these patients get that high touch for a very concentrated point of
Mhm.
time. And then they're out on their own and they don't
Yeah,
have to be.
yeah,
There's so
yeah,
many of us who can be supporting them
yeah,
through those
yeah.
transitions. So, thank you for bringing that up. That's such a good way of diving into what this is and what we can be doing. So, when we think about cancer survivors, Dr. Nalini, who are we talking about? Is it a diverse group of patients? Is it people who are in remission? Are others living with chronic issues post treatment or post cancer diagnosis? Are there a variety of concerns that would be top of the list for you? That's a lot packed in there, but I'm wondering, like, who are we talking about? I always like to do the what, why, who, how,
Mhm,
now.
mhm, mhm,
So
mhm.
who are we talking about?
So it is a very diverse group of patients. If you just think about, could be different age groups. The demographic is mostly people over 50, but dealing with a young woman who is in her 30s who got diagnosed with breast cancer is very different than
Right.
dealing with an 80-year-old who, just had a breast cancer treatment. And so the time in the life cycle, what's important to people at different times in their lives, that's important. People are diagnosed at different stages of cancer. So some people really have no evidence of disease when they are done with their treatment, and that's remission. And so the job then is to keep them in remission and understand how to change the tumor microenvironment and the cancer terrain, how to create a biosystem that's not hospitable and supportive to cancer. That's true of every survivor. But there are advanced cancer patients or people who are recovering from a recurrence that really might be living with cancer as a chronic illness. And this is actually a very huge underserved population of cancer
Hmm.
survivors, right? And,
Hmm.
we want them all to be thrivers, but there
Yeah.
are some patients, for example, colorectal, prostate, and breast cancer patients can live a very long time after their treatment, but they might live with some residual disease. So that
Mm,
cancer is a chronic illness. We have to reframe that as if it's diabetes or hypertension, that we'll manage it, right? And
right.
so they could live a long time, like my parents lived a very long time and didn't die of cancer. But my dad had some residual prostate cancer all that
Mm.
time, right?
Mhm.
But cancer wasn't on the front burner of his
Mhm.
disrupting his life,
Mhm.
and but that's because we managed it well. And
Right.
so I think thinking about people who are in remission and people who are living with cancer as a chronic illness, those are two different groups. And then the over
Mhm.
50 population is always going to have comorbid concerns as well. So they tend to
Right.
be complex patients. And that's why we are a good resource for them, because we're not in silos. We can treat the whole person.
Yeah, I was gonna say, it brings us back to the
Yeah.
matrix. Like, we have to bring a
Yes,
lot of empathy to who they are,
yes,
where they're coming from,
yes,
what the
yes,
antecedents are, the triggers. The triggers are certainly the treatment in and of itself. We have to
yeah,
remember that
yeah,
and not
yes, yes,
overlook that the treatment itself is a trigger, what we know is working, and then look at the whole terrain. And as you said, the terrain is one in which we do not want to make the environment hospitable to cancer, and we want to be able to think long term in terms of what health and survival looks like. And so, really bringing that individualized approach to each and every client or patient. It's interesting that. I mean, I'm curious your thoughts on like what's happening in precision medicine with cancer
mhm, yeah,
treatment.
yeah,
And I'm
yeah.
always questioning why we're not looking at a precision model in health care, in post cancer care.
Oh, well,
We are, but like,
yes, yes, yes.
why is that not part of the paradigm?
Because it's still a pathology oriented paradigm. If you're doing precision medicine, you're looking for root cause. You're looking what's unique in an individual to put a treatment plan together. And that's just not how physicians are trained for the most
Right.
part. It depends on what your specialty is.
Yeah.
But, you know, cancer in some ways, oncology is more forward thinking in what personalized medicine actually is. But,
Right.
you know, if we go back to our basics, like, you know, every cancer patient needs their microbiome rectified, because the treatment itself is disruptive.
Exactly.
But, you know,
Rectified is really critical there, right?
yeah. And so chemo just wipes out the healthy microbiome. Radiation to the pelvis
Right.
really disrupts the microbiome and the vaginal microbiome as well. And so, you know, kind of going back to our basics, so what are the fundamental things that cause and sustain health? These are really important. So as part of our framework, you know, we have that sort of ground to really teach patients what causes health. And I also say to patients, it's really more important to understand what causes you to thrive than what's wrong, so that you're in a health model. And, you know, all cancer patients have a fear of recurrence. Everyone who's ever had cancer of any kind has a fear of recurrence. And so that anxiety is reduced by having actionable things to do in your life that are life-giving, not cancer-killing, right? And so it's a reframe. Like, one of the things we do for patients is reframe for them. And I always say, okay, now the conversation is about health, not about disease.
So
And
good.
and just that, you know, just that, it's like, oh, you know, I don't have to think of myself as a sick person. And so then we get to teach about health, right? And so maybe that wasn't even part of their interest before they had cancer. And so there's some people that are really starting at the beginning. There are other patients that come in who already were oriented towards healthy eating and a healthy lifestyle, but then they have to learn about the new body they find themselves in that's not familiar to them. And so we can really help. So much of what we do is not just, you know, what we prescribe, but how we help the patient learn a new relationship to themselves.
Yes. Yeah, so important. And reframe is one of my favorite words for how we create a framework for reframing the whole relationship to health. I'm wondering if you see people who come in who are diagnosed with cancer, who were concerned with all the things, right? Who did do all the things, feel angry or resentful that they were doing everything right, and still, because, you know, a lot of my concern is chronic illness, particularly autoimmunity and any chronic conditions that are not easily resolved. And I know how frustrating it can get for people when they're like, but I was doing everything right. And still, and then the relationship, not just to their body, but the trust in all the things is a little disintegrated.
It can be, and some people feel betrayed by their body. Some people feel like, I did everything right, and why do I have cancer? And, you know, my answer to that is, you know, cancer is a perfect storm between our genetic susceptibilities and the environment we live in. And we don't get to pick any of those initially. You know, you can take control of the water you drink and the air you breathe in your house, but not when you walk outside the door. And so, you know,
or the stressors you experience, or like so many things, like we juggle them to the best of our abilities.
Or like diabetics have a 40% higher risk of cancer because of hyperglycemia and hyperinsulinemia are growth signals. So when we teach patients how to manage their glycemic control, their risk goes down. Breast cancer patients who are obese or just have too much body fat in terms of their body composition have a much higher risk of recurrence. So there are things that the oncologist doesn't tend to that make a difference in whether or not you have a recurrence. The amount of sleep you have, the amount of exercise you get, the regulation of your parasympathetic and sympathetic balance is really important. Now I have people get Oura rings and monitor their heart rate variability so that they can understand how they respond to stress. And
Right.
it's a good biofeedback tool for people who are interested in having one.
Yeah.
But really helping people to shift from fear of recurrence and the sort of the disenfranchisement of being an oncology patient, feeling like other people are making decisions about your body,
Right.
to taking control of that, having a sense of agency, and feeling like you have tools and a plan and a map so that you can go forward, rebuild your health from your short-term and long-term adverse effects of your disease and your treatments, and that you're headed towards health. And, one of the things I say is if you don't have a plan for your health, that's not going to be your outcome. So that's something we really bring to the table for these patients.
Yeah, I want to get into both short and long-term common impacts, but I
Yeah.
just want to underscore, Dr. Nalini, the empathy that you're speaking into, which is also missing in a lot of clinical care, and which you and I both highlight in our training in terms of like what that experience is like for an individual who's been through this shock and the burden and the change of the life. And I know I've shared this with you before, but when my husband was diagnosed with his glioblastoma, with his brain tumor, the moment that was really the most traumatic for him was when they went to put a port in his arm for a CT scan. And then after the CT scan was done, and he said, "Are you going to take that out?" And they said, "No, we think we'll just leave it in." And he felt like, now I am the property of the hospital. And that was the moment for him that was bigger than receiving a diagnosis. Like, it was the moment where he felt like, I am no longer my property. And giving people back that agency and recognizing the trauma that they've been through in not just receiving a diagnosis, but everything leading up to that is so critical in how we recognize what this person has been through. Like you said, not just giving them treatment protocols, but being.
Yeah. There's a model that came out of the Sims-Mann Integrative Oncology Center at UCLA. The director there was a psychotherapist who specialized in post-traumatic syndrome. And she defined the cancer experience as a series of traumas. And that, in fact, cancer survivors very much resemble patients who suffer from PTSD, and that they get re-triggered, and that they hold the trauma in their body as well as in their psyche. And that, when you take a shower and you look down and you don't see a breast there, that's a trigger, right?
Totally. You walk into that hospital where that conversation happened. And yet, like, we can't assume that we know what the triggers are. They may be buried in this moment that we have to hold space for, and not assume with our own bias that we know where and what those triggers are. Because, like I said, receiving the diagnosis may not be the moment. There may be all these other micro moments that are triggering.
And understanding what's important to that person. There's a beautiful book by Dr. Otto Gawande called Being Mortal. And when I teach my course, the very first lecture is about that book, in which he asks his patients, he was an end-of-life palliative care physician, and he asks his patients, what's important to you? And so how we're never trained to ask that. We just come in with our ideas of what a great treatment plan is. But if you understand what's important to the patient, you know how to speak to them, you know how to address. So for some patients, being able to stay alive as long as possible for their children is important. They don't care that they've lost, several body parts or that they're in pain. They want to be there as long as they can for their kids. Other people are happy if they can eat an ice cream cone still, and so, you have to hear, like, if I have a breast cancer patient who has 2 young children, then her concerns are very different than someone who's a grandmother and is at the end of their life. And so, and I always ask people what gives them strength, what gives them courage, what their spiritual life is like, what inspires them, what gives them hope. I want to know who they are, what kind of internal resources they have. And I also want to know what kind of support system they have, because I practice in a international city. And so if I have a Latin patient, then I have to have 8 chairs in my consult room because the whole family comes.
Right,
and then
right.
they're, you know, and that's different than a single woman with no family here and not very many friends, supports herself, doesn't have a great support system, and kind of goes through it alone. And we're her support system. And
Right,
so,
right.
you know, that's a very different experience.
Yeah. Yeah. I just kind of wanted to double click on that because you bring such beautiful empathy and that spiritual piece, Dr. Nalini, that you weave into the medical and the clinical is so key to this process. I think also when we're working with cancer survivors or cancer patients, recognizing when they are done and holding that and not being in the bias of our fight for what we believe they want or what their family
That's
wants.
right.
And
That's right.
I've seen that be so hard for clinicians. And I've had the privilege, as I'm sure you have had more than I have, of sitting with people in, I'm done with the fight. This is hard. It's painful. I don't want to hurt the people around me, but that's a different conversation.
Yeah.
And we have to
Yeah.
be ready for all parts of the conversation. But in order to do that, we have to do discovery with who this is and what
Yeah.
they've
Yeah.
been through.
Yeah.
And you do that
Yeah,
so
it's really
beautifully.
important to know who it is that you're
Yes.
sitting in front of. Then you can build a treatment plan that is appropriate to them, that doesn't overwhelm them.
Yeah.
Some people, you know, want to take quantum leaps, but most people are baby steppers. Cancer itself is very overwhelming. And
Yes.
so it's really important to match your treatment plan to the current state and capacity of the patient. And I also say to patients, you know, it's an extraordinary opportunity for self-reflection, to
Yes.
really think about what's really important to you, what your core values are, what your priorities really are. And a lot of people really change themselves and change their
Yeah.
lives. And so at the beginning, I try to give them that framework, that you're walking through a gateway that is potentially deeply healing and deeply transformational, whether you live or not, whether you live a long life or not,
Yep.
but that you know who you are and what's important to you.
Yes.
It's an opportunity for that.
Yeah.
And the other thing is, a lot of people have feelings come up during their cancer journey that they don't really want to share with their family members because
Mhm.
they think it will upset them, you know, so
Yes.
they talk to us about it, you
Yep.
know, they talk to us
Absolutely.
about it. And, you know, the other thing is we're sitting before people who are facing their mortality.
Mhm.
And what I learned is that you have to wait till somebody is ready to talk about death.
Yes.
And although I'm comfortable talking about it, you have to wait till the patient's
Absolutely.
psyche arrives there. And so I do what I can to let them know they can talk to me about anything.
Yep.
And I asked for patients to make statements about their experience. And I had one patient say, Dr. Nalini's not afraid of cancer.
Mm. Mm.
So, you know, that's an interesting perspective from a patient, you know.
Yeah. Yeah. It's beautiful too. It's profound. So
Yeah,
much in that
yeah,
short
yeah,
statement. Okay.
yeah.
So now short-term effects beyond trauma to the physiological system. How do you talk into short-term side effects for the
So,
cancer patient?
so for example, some people will have neuropathy. Some people will have, you know, disrupted digestive function from
Yep.
the top to the bottom of their GI tract. Some people will have sleep disruption, residual pain. Uh, Remember that also people are adjusting to being in a body that might have been disfigured by the cancer, and
Right.
that a lot of relationships have changed, sexuality changes, body image changes. So all of these things are going on simultaneously.
Yeah.
After chemo, a lot of people have bone marrow suppression. So the most common complaint of cancer patients, both during treatment and afterwards, is fatigue. And so you have to do a sort of differential diagnosis and discover what the source of their fatigue is. And so 80% of patients undergoing treatment complain of fatigue, but up to 20% of patients can continue to complain of fatigue even after successful treatment for up to 20 years. There's a wonderful physician at UCLA, Dr. Patty Gans, G-A-N-Z, whose life's work is studying long-term survivors of breast cancer. And what's interesting about her work is that the primary cause of higher levels of fatigue during treatment, that this ongoing fatigue, is patients who have single nucleotide polymorphisms for higher levels of inflammatory cytokines. So you can, just by taking a history of someone and seeing if they have more inflammatory syndromes, kind of predict that they might have more cancer treatment related fatigue and also more cancer related fatigue. And so that is management of inflammation is often one of the solutions to cancer related fatigue. So that generally needs our attention. That's something really not addressed by the oncologist.
Right.
And you know, a certain amount of sleep disruption is experienced by cancer patients, but you also have to figure out why. Is that because they were in the hospital and they were woken up every 4 hours, or is it because they have pain waking them up, or is it because they're anxious? You know, so you know, we have to still find out what the root cause is of their symptom, the symptom being the endpoint of something, not the thing we have to treat, right? And so, you know, I do an inventory. I ask people what they're experiencing. And, you know, some people still have incision-related pain. Some patients who've gone through, say, ovarian cancer patients have had maybe multiple surgeries or lots of inflammation in their pelvis, will have adhesions. And so they'll suffer from constipation and abnormal transit time or abnormal peristalsis because they have fibrous tissue around their intestines. So, you know, you want to see not only what's happening, but what feels the most disruptive to the person, right?
Yeah,
that's
so
what's most important. What's most important question.
Yeah.
So, for example, colorectal cancer patients who have had surgeries on their lower intestines or on their rectum or their anal sphincter might have poor sphincter control, and it can have up to 20 bowel movements a day because they don't have good sphincter control, and those bowel movements might be painful. And so that's the most disruptive thing for that person.
And like we know, exactly. And we know then how that's causing more toxicities and leading to more, I think of it as roots and branches, right? Like if we can think of all those branches, which are those symptoms, including the cancer diagnosis itself, how do we go into that terrain area that you're talking about and ask the right questions and make the right decisions? So how do we do that? How does your system help us to think through where we're spending our time? I mean, I don't know, Nalini, we both train clinicians of all sorts of backgrounds. And the reframe for the clinician to get out of the Band-Aid, even if they know the Band-Aid and the system is broken, is very, very hard. It takes a lot of work and a lot of self-realization and wake up for the clinician to recognize I'm not just putting a Band-Aid on things. I'm not here to fix the symptom. I'm here to address the terrain. So how do we do that? How do you teach that? How does the OutSmart Cancer system get us there?
So, you know, you have to be in a functional model. And, you know, that could be functional medicine, could be Chinese medicine, you know, it could be a naturopathic model, where you still want to understand the whole biosystem, and you want to understand the fundamental functions that cause health. Those have to be in place. So if someone has mouth sores and they can't eat because it's painful, then we not only have to heal the lining of the mouth, but we have to give them nutrient density, maybe in liquid blended foods and shakes, until their mouth heals, so that they are replete with their macro and micronutrients. So
and you not give them Ensure like they're getting in the hospital.
You know, you have to be pragmatic, I think. And you know, there's nothing wrong with giving symptomatic comfort
Correct.
while you're solving a functional
Absolutely.
problem, which could
Yes.
take some time. Like it takes
Yes.
time for the bone marrow to come back, you know? And so patients need to kind of understand what's a reasonable expectation. So patients tend to be trained to watch their cell counts of their red and white blood cells while they're going through chemo. And when they don't see them come back right away, they get anxious. So, you know, patients need to understand it could take 6 to 12 months after
Right.
myelosuppression from chemotherapy for your bone marrow to recover. And so
Yes.
while we're doing that, you know, you just have to be compassionate to yourself. Patients need to learn to honor their limits. You know, when you are anemic, you don't have the same oxygen carrying capacity. You can't work out as hard. And
Yep.
so, you know, patients need to have context for what's
Yes.
reasonable to expect of themselves and not feel like something's wrong, you know?
Right.
And, you know, so we can help educate them about what's a reasonable expectation of recovery. So bone marrow suppression is what I consider short-term side effects being 6 to 12 months, right? So a neuropathy may take that long for nerves to repair, for the myelin to repair, for the redox reactions to be quenched so that you don't have that constant oxidative stress. It's
Yes.
the rhythm of nature. And so one of my loves is Chinese medicine, which uses the map of nature in a very poetic way. And so, you know, I talk a lot about seasons and how long things take to change and what's reasonable and what real healing and repair is, not just symptomatic quick fix when you take a drug that masks the symptom, but what does it really mean to, you know, rebuild your microbiome or repair nerves? How long does that take, you know? And so patients have no context for that because medicine isn't practiced in repair and restoration. That's not the experience a Western medical patient has. And so the expectation is things should happen fast. And so we have to say, no, the rhythm of nature, real healing, real change in function, and real repair of structure takes time.
Yes. Yeah. And that education is really critical. Our ability to educate and hold the space for that reality and to go move out of the quick fix. While, as you said, if we need to bring systematic comfort, yes, all for it while we're doing that deeper work and shifting the terrain in which those signs, symptoms, and even diagnoses exist.
Yeah, and you know, like I have a patient I actually just saw yesterday who's completed a year of hormonal blockade as a prostate cancer patient. You know, he does not feel like himself, you know, and so feels tired, he's lost muscle mass, he's lost libido, he can't exercise the way he used to, and he's a little depressed because hormones affect mood. And so, you know, he doesn't feel like himself. He doesn't feel well. He needs to have some hope that he's going to feel better. And so, you know, I think that there's a place for adaptogenic herbs, for example, to support the stress response, and in Chinese medicine, the qi, the vital energy of life, so that people can, you know, start to feel reconnected to feeling well and feeling energetic. You know, that fatigue thing is really a big thing. The other thing that can be both short-term and long-term is cognitive changes. And so, for example, I had a patient who, and breast cancer patients have a lot of cognitive changes. And these are often in memory and executive function. And so if you're a professional, I had a woman who was an attorney who said, I can't do my work. My mind isn't there, you know, my mind is not there. So oncologists don't know what to say to these patients, but we can give them omega-3 fatty acids, correct their microbiome, give them Chinese mushrooms like lion's mane is known to improve cognitive function, make sure they have all their methylated B vitamins, all the things we do to make a healthy nervous system, but also tell patients, if you want your cognitive function, you have to exercise and you have to sleep, right? And you have to take care of your blood sugar, you know, all the things we know that, you know, and so, but, you know, think about it. If you are persistently fatigued and you lost your cognitive clarity, your ability to remember things clearly and sort information, then you are really not yourself. And so acupuncture is also really wonderful for this kind of restorative kinds of therapies to get function back and really treat from the bottom up, really support the foundation. So I have a great love of Chinese tonic herbs for these patients. And there's a tradition, both in traditional Chinese medicine historically, but in modern China, there's a modern Chinese herbal medicine that there are very specific formulas, for example, designed for post-chemo bone marrow suppression. And so, you know, there are good solutions that are research-based that we can give to patients. There's a lot of brain inflammation with cancer. The blood-brain barrier tends to be impacted in the same way that the intestinal barrier becomes breached when you have systemic inflammation. And so that's the cause of some of the fatigue, mood change, and cognitive deficits. And so we can you know, use our rebuilding restorative therapies for these things. So, you know, the way I build a treatment plan is to think, what are the fundamental foundational nutritional needs that are unique at this stage of the game for this person? So put those in. And then what are the targeted things for the issues, that the dysfunctions that they're having right now? What are the targeted things? And then what are kind of the insurance policies that we can put in if somebody doesn't eat perfectly every day? So a lot of cancer patients and cancer survivors, they don't have normal digestion and elimination. They're not that interested in cooking. So I'll always put in a therapeutic shake into their plan and put, you know, greens or reds powder in there until they're interested in real food, so that we still are making sure that they are replete in their nutrients. Sarcopenia is part of cancer physiology, and it's also part of aging physiology. So the demographic of cancer patients is very at risk of losing muscle mass. And so we have to have a plan for that. And if they're not going to eat a lot of food, then we have to have a plan. So I like to use things like bone broth, and I like to use shakes, so that we can make meal replacements and easy ways to get nutrients. And I think bone broth is one of the great therapeutic foods during and after, to really restore the lining of the gut, to give a lot of minerals, and also to really give some protein in an easy way. Like a cup of bone broth has 10 grams of protein in it. And so, you know, if you want somebody to get 60 grams of protein a day, they, you know, what if they drink 3 cups of bone broth and that they got half of it, you know?
You're singing our tune here in the functional nutrition realm. And I know you have a gift for everybody here with some information. I just also want to speak into, before we share that, and I'll put it on the screen as well, Dr. Nalini, but you're giving so many great tips and so many good ideas. And I also know you said a treatment plan and the seasons. And I know a lot of clinicians can want to do too much too soon. And we have to remember again the state that this person's body is in, and not to overwhelm the system. And so I'm just hoping you can speak quickly about the fact that it is a plan, that it is over time, and that it does pivot a little bit, or how you speak into that, because I know there can be a rush to, like, here's your smoothie and here's your bone broth and let's get all these supplements on the table and herbs and your mushrooms.
Well, I actually tend to do that. So, but I have a nutritionist in my practice that helps the patient implement, you know, and if they need to go in baby steps, or understand how to get organized, understand how to shop, all of that. So I'll often put the whole plan together, but then my nutritionist will help them to implement it at the pace that they can. So
yay for the nutritionist who can figure out that pacing.
And so some people, you know, have already been used to taking supplements and herbs and making shakes, and some people go, how do you make a shake, right? So, you know, it depends where the person is at and what they do or don't find overwhelming. Some people have their anxiety reduced by doing all those things. And so, you know, and are ready and psyched up and ready to go. And so, you know, it just depends, you know, who it is, you know, who it is important. But, you know, cancer is a marathon. It's not a sprint.
Right.
And the recovery of cancer is long, and repair is long. And so, set up that expectation for the patient, then they can say, okay, a year from now, I'm going to feel like I'm healthy again. And that's reasonable. That's really reasonable. So just set up that expectation. Also, you have to kind of understand somebody's process-oriented or goal-oriented, so you speak to them in a language that makes sense to them. I tend to put the whole plan together and then give them to my nutritionist to help them implement that so that they don't feel overwhelmed or lost.
Yeah, shout out to the nutritionist. So beautiful. Love it. Okay, so I know you have a gift for us all here. I'm putting that link here on the screen. Can you tell us a little bit about this?
Yeah, so, in a limited amount of time, we can't talk about everything. So I have created a resource for clinicians, and it contains protocols for coping with side effects of cancer and cancer treatments. And it also, there's a second part to it that just lists the common side effects so that you know how to take a good history, right? So, to ask about, are you experiencing this? Are you experiencing that? So it's a kind of a cheat sheet, but it's actually some examples of protocols also. So my wish when I teach is that clinicians have something actionable that they could do with a patient tomorrow, from the talk. So we have that. And then for those people that are interested in actually getting deeper training and studying my OutSmart Cancer system and having life mentoring, my course, Foundations of Integrative Oncology, teaches this system. And we have an offer of a 10% discount through the end of June for all of your community. And the code at registration would be Nakayama 10.
Nakayama 10.
So they can get the 10% discount for being part of your world. Yes.
Beautiful. So Foundations of Integrative Oncology, if we get the handout, the cheat sheet, will we learn more about the course there as well?
There's a back page that describes the course and tells you where to go to register, but you can just go to the AIIORE.com site/courses, and you can take a look at what's in the course and all the 8 modules and all the big resource library that we have. There's 30 hours of me lecturing in the core curriculum. And there's about another 30 hours of advanced lectures and case studies and things as well.
Brilliant. Yeah. Any closing thoughts, Dr. Nalini? It's such a joy to have this level and depth of conversation with you. Do you have any closing thoughts to share?
I do, because every single clinician has patients in their practice already who either themselves are a cancer survivor or a family member or a good friend who's been touched by cancer, because 1 in 2 people in the United States will be diagnosed with cancer. And all of those people are looking for a health model. And we have a health model. So you can start right away with the basic things that need to be tended to, like get their diet together, get their blood sugar together, fix their digestive tract, fix their microbiome. You can start, and the impact is huge. And I would say it's, for me, the most meaningful thing that I've ever done in my 35 years of practice is work with cancer patients.
Yeah.
Because it's such a big need, and there aren't enough people that really understand the needs of these patients. And they're so grateful, and it's just so meaningful, And so I would say, with your training, people are already prepared to offer something to these patients. And then if you want to take a deeper dive and really understand cancer and cancer physiology and more complex level of helping patients, then come to my training. And quite often, if people call me and they don't have that foundation, I first send them to you and say, come to me after. And so there's some people in that position, but to just let people know with the level of training you have right now, that you actually have things to offer these patients.
Totally.
And if you let your community know that you are available to be a support person for the health side of the cancer equation, you'll have a waiting list. You will have a line outside your door, because there are that many people who are looking for this kind of support.
Yeah. And that's your legacy, Nalini, just that there is this need, and it's so vast, and there are not enough people filling it. if we have 1 minute, can I ask you a question that came in from Teresa, who's
Yeah,
here with
yeah,
us?
yeah.
So Teresa's asking about the bone broth, and I'm going to see if I could show her question here. I do not and have not eaten beef or pork in 18 years. What can I eat in place of taking collagen? She didn't mention chicken, so I don't know if she can do chicken broth.
Yeah.
But do you do like marine collagen, or do you use other kinds of collagen in place of animal
You know,
collagen?
you know, collagen is a protein. So if you're vegan, you just need high quality protein in your diet
Yep.
to rebuild tissue, And so, bone broth is nice because it's a drink.
Yes.
So,
Easy on the digestive system.
but there's no equivalent. Collagen is a animal-based protein. So if you don't want to eat animals, then you just need to get adequate grams of a digestible vegan source of protein. So I like to use like organic pea protein powders, for example, so that somebody has mouth sores and they need a liquid drink. Something like that is simple. You can make blended soups out of beans or tofu if you tolerate those foods. And, you just need a good protein source that you can digest.
Yeah. And there's definitely chicken bone broth, and there's fish. I've had some amazing fish bone broth that's made traditionally,
Exactly. Yeah.
if those are eaten. But I think it's just getting creative with what are we trying to use that food or nutrient for, and what are other ways, like you're suggesting, that we can get that. And in this case, the healing properties of the protein.
Yeah,
Great
but
question, Teresa.
It's the bones we're cooking
Yes.
down. So whatever, if you eat fish, you want to get fish bone broth, you're going to cook down fish bones. It just takes more of them.
Yep, exactly. Okay, so beautiful, Dr. Nalini. I adore you on so many levels, and all that you bring to the care and to your teaching, which is phenomenal. I'm sure everybody could tell by our time together today how phenomenal your teaching is. I'm going to go ahead and just put that gift up again on the screen here. Thank you again, Dr. Nalini, for the time together and for answering questions, mine and others, and I will see you soon.
Thank you for having me. Thank you for your support.